Good evening, doctors and all participants. I am Dr. Rizin Kusab, the Secretary of Association of Private Practitioners Sabah, APS. Happy New Year 2022. Welcome to our first free live streaming this year, brought to you by our association. During the session, if you have questions, please write them down on the comment section in the YouTube platform earlier than later. The question will be addressed by speaker at the end of the session. Our speaker this evening is Dr. Giri Shan Rajahram. Welcome, Dr. Giri, all the way from UK. Dr. Giri is currently doing further training in UK. As such, he will be delivering our talk this evening all the way from UK. I believe it's cold winter over there. I hope you keep yourself warm, Dr. Giri. Dr. Giri Shan Rajahram graduated from Science University of Malaysia in 2006 and got his MRCP from UK in 2011. Since then, he has received several qualifications and appointments from several institutions, including the latest in 2019 FRCP Edinburg. He has numerous publications under his name, as can be seen from the CV I posted earlier in the WhatsApp group. Dr. Giri Shan Rajahram is currently the infectious disease consultant in Queen Elizabeth Hospital, Kota, Kinabalu, and technically still the head of Department of Medicine in Queen Elizabeth Hospital too, albeit he is on study leave at the moment in UK. He's actually in University of Oxford doing his Master International of Health Tropical Medicine. He'll be adding another qualification to his long list of credits. The topic he will be delivering today is the latest about COVID-19. I'm sure Omicron will be in our head throughout this talk. Ladies and gentlemen, I present to you Dr. Giri Shan Rajahram all the way from UK. Dr. Giri.
I was just saying thank you again for the organizing committee, and always a pleasure to speak to people back in Kota Kinabalu and Sabah. So what I'll try to do today is take you through a little bit about COVID and what we know about COVID. I think most of us are very bit familiar. Most of us are familiar about COVID in this clinical presentation. Then I'll try to speak a little bit on the situation of Omicron and what we might expect to see. Obviously, the huge wave is not hit Malaysia yet, but potentially at some point in the near future. But what I try to do is give the experiences from a UK perspective and what's happening here, and then perhaps a little bit a discussion on vaccines. So we'll start off with a case. Here we have Madam SG, who's a 40-year-old lady, has comorbidities of diabetes and hypertension. She's a bit overweight as well. You can see the BMI of 38. She came in with a history of fever, cough, and shortness of breath. Very rapidly. Okay. Okay. All right. Now. All right. Okay. So she presented a history of fever, shortness of breath, and she had an RTK positive. And this was a chest X-ray on admission. If you can see, she rapidly deteriorated. If you look at the PaO2 of the oxygen, requiring a high flow mask. Subsequently, she deteriorated, requiring high flow nasal cannula, and then she got better over the time. If you can see the clinical markers here in presentation, she had a high CRP. We went up to a maximum out of 128 before it came down. So what therapies did she have? When she came in, she had steroids. She was immunomodulated with tocilizumab, which is a inhibitor of interleukin-6. and she was given antibiotics. So what essentially happened is she came in with a phase of hyperinflammatory. She was given immunomodulators to sort of dampen down the immune response, and she responded pretty well, and she got better, and she went out of hospital. And that's a classic sort of situation you see most of the time for patients who present in hospital. Usually they have underlying medical conditions, for example, diabetes, hypertension, renal failure, and they have had symptoms for about a few days, and they deteriorate usually after day 5, day 6, and come in with shortness of breath predominantly as a presentation. And if you look at the Malaysian clinical categorization, and this is something I think most of us are familiar with, category 1 is asymptomatic, 2 is symptomatic with no pneumonia, 3 is symptomatic with a pneumonia, 4 is somebody requiring supplemental oxygen, and 5 is patients usually in ICU with critical illness. The first 3 stages is considered mild, stage 4 and stage 5 is considered severe. Previously, I think we were a bit more robust. We tried to get all the people in who we started off with trying to get everyone in. We eventually progressed to get people who are symptomatic with high risk. And that's where we are now. So you have high risk, if you have symptomatic disease, you will get admitted. Otherwise, if you have a suitable home condition, you'll be quarantined at home. And this was one of the early studies from Malaysia, which looked at mortality rates for patients who had COVID-19. This is age-specific mortality. I think we all recognize the older the person gets, the more underlying comorbidities the person has, the higher risk of death from COVID-19 itself. And this is a trend that's replicated everywhere else in the world as well. Again, early Malaysian data showed quite consistently, if you had medical conditions, you had higher risk of hospitalization, higher risk of severe disease, higher risk of ICU admission, and also higher risk of death. In this particular study, chronic renal failure was a particular comorbidity we were concerned about, and that translated to a lot of patients we saw in hospitals as well. And I'm sure most of you all would have seen in your clinic setting, patients who naturally have these comorbidities have a higher risk of deteriorating from any medical condition. And of course, in the context of COVID-19, they're higher risk as well. We found CRPs very helpful. If you had a CRP of more than 50 or a rapidly upgoing trend, it definitely indicated that these are patients that we want to really watch and follow them up. And in particular, in hospitalized patients, it correlated quite nicely with disease progression and obviously getting better as well. So you had patients who had a creeping up CRP or a suddenly rising CRP and they deteriorated in hospital. So that's a good biomarker you could look at for patients who are who might be at risk and you were concerned about. And this is again from the Malaysian guidelines. When we're looking at severe disease or who is at risk of progressing to severe disease, you ask the 3 questions: the who, the when, and the how. So the who is usually patients who are older, more than 50 years old. If you have a comorbidity, I think you have lists down there. I think something that came through quite markedly during COVID-19, I think we generally knew, but quite markedly came through in COVID-19 is obesity. If you had patients who are generally never had any other comorbidities, but if they were obese, particularly a BMI of more than 30, 31, of course, if it's more, it's worse. They didn't do well, as in they had risk of developing severe disease. When usually day 5 onwards, and day 10 would be the critical phase of somebody progressing to developing severe disease. And the how, what you look at clinical features, you look at laboratory features, you look at radiological features, clinical being persistent fever, persistent symptoms of lethargy, anorexia, respiratory symptoms. And again, respiratory symptoms here, you had the situation of heartbeat hypoxics, where you only found them to be hypoxic if you did SpO2 monitor. And generally, I would say SpO2 monitor, regardless, the patient looks well, the patient looks otherwise quite comfortable, doing a point of care saturation test. after doing a sit and standing. So what you do is you ask the patient to sit and stand for a minute, and then you check the saturation. If there is a desaturation of more than 3%, that's a good indicator that the patient might progress to develop, go on to develop severe disease. It's also an indication for referral for hospital admission. The biochemical parameters we spoke a bit about. The CRP is a good trend. And radiologically, if you have anybody with X-ray or a CT scan which shows pneumonia with COVID-19 positive tests, that's an indication to get these patients to hospital most of the time as well. So those were things that we looked out for patients. And the kind of deteriorations we usually see, three big groups. One is first of all, is the severe disease from the so-called cytokine release syndrome or hyperinflammatory phase. These are patients who have viral pneumonia and their body is hosting an inflammatory response, and that goes aberrant, and you have rising CRPs, you have dropping lymphocyte counts, and the interleukin 6, if it's available, it's high. And these patients, when they present with hypoxia, usually get steroids and immunomodulators if the situation is not too good. And then you have patients who have medical conditions who worsen. For example, somebody with chronic heart failure, congestive cardiac failure, who gets COVID-19 and gets tipped into acute heart failure. So those are the second group of patients who deteriorate and see in a hospital. So first is those with hyperinflammatory syndromes. Second is just the underlying medical condition gets worse. And the third is a viral pneumonia phase, and usually it's patients who present quite early. Usually you see younger patient more than older, although you can see it in the older group as well. And this is basically, you don't have the classic features of hyperinflammation, but you just have an X-ray which looks aberrant, and you have a patient who's hypoxic in front of you. So those are the patients who have a predominant COVID pneumonia as the tipping off factor. And I think most of us will be familiar with this trend from Malaysia. So you've seen surges, and obviously this is if you could see this peak here was for the previous Delta wave. And the two things we look at, the case counts, and number two, we look at the case positivity rate. The case counts is obviously a downgoing trend at the moment. And if you can see from the peak in Delta where we had 2020, nearly close to over 20,000 cases, I think now we are hovering about 2,000 to 3,000 cases a day. The test positivity rate at one point during the Delta surge, it used to be up to 10 to 15%. I think now we're about 3 to 5% in most places in the country as well. And these are figures for deaths, patients who are ventilated, and ICU usage in the country at the moment. So if you look at the patients ventilated and the patients at ICU at the moment for COVID, obviously has come down from the previous peak when we had nearly 900 to 1,000 patients in ICU with COVID-19 at that point. And I think one of the key success stories in Malaysia is how we've got our vaccination of the adult population up to such a high percentage. I think when we talk about vaccination rates in the world, we in fact do better than countries like the US and United Kingdom. And yes, Singapore is probably higher, but I mean, the context is Singapore is a very different demography in the sense that they are a city, island city. So, Malaysia has done really, really well when it's come to its vaccination rates and its vaccination uptake. And this is the share of vaccines which was being used in Malaysia. So the large majority being Pfizer, then closely followed by Sinovac, a smaller percentage of AstraZeneca, and CanSino in a very small percentage. And I think this is very, very illustrative, the difference of death between somebody who's vaccinated and somebody who's not vaccinated. The gap here is, speaks and tells you the whole story of the benefit of vaccines. I just put up this slide to show Sabah. Sabah will hopefully do better when it comes to fully vaccinated percentages. Obviously, there's a lot of hard-to-reach populations. There's a lot of outreach programs where the teams go to the communities to get them vaccinated. But we obviously would want to get these numbers to close to 80% for us to be comfortable moving forward. So I think maybe late last year, towards November, December, we heard about the new variant called Omicron. And just for a context of the 7-day rolling averages of cases in countries which have seen Omicron here, I think you can see just illustrative from the slides, the absolute case numbers have just taken off exponentially. If you look at United States here, they're seeing something like these are counted cases, all right? So this is about 700,000 counted cases a day, and we know obviously there are a lot more people who are not diagnosed with COVID. So the true measure might be in a few millions in the United States. And if you can see countries like France and United Kingdom, the same trajectory. And a lot of times the surge has gone past the previous Delta surge. All right. For example, if we look at the United States, the surge from the previous Delta wave as compared to the current Omicron wave, it's illustrative. It's much higher than what it was from the Delta surge. And I put two other countries here of interest. Malaysia, we've obviously not seen yet the surge. Will we see? I think it's a matter of when rather than if. So it's going to be at some point. I put India here because it's probably going to be the next epicenter, because the situation in India, I think we all know it's usually very, in urban settings, very urbanized, very close, and a lot of slums as well. So it's going to be a place to watch. And Malaysia, Indonesia, whereas these regions have not, we've seen cases, that means we've seen imported cases, we've seen some small number of local transmission, but we've not seen the real surges that the countries in Europe are seeing and experiencing currently. So what is it that about Omicron that makes it sort of different from the previous Delta wave? What we know is it's incredibly transmissible. A lot of people who get infected have had infection before. That means people who have got infection can get reinfected before. That's number one. We know from household studies, that means people who had COVID and their household context, there's a higher proportion of people who get COVID-19 if there's an index case in a hospital. And the interval times for doubling, that means the growth exponentially is every 2 days. That means if you had 2 cases today, you'll be 4, tomorrow you had 16, by next day, and you're by 256 by day 4. So it just grows exponentially every 2 days. And the thing about exponential growth is once you have time to realize it's there, you've already sort of had thousands of cases in the community to begin with. And that's this thing about evasion of antibody response or the humoral response. There have been studies to show there is perhaps some evasion of the neutralizing antibody response, both from convalescent sera and also vaccines. But I think there are reassuringly a lot of studies showing the T cell response or the longer term response from the body itself is still quite robust, particularly for people who've got vaccinated and boosted. Virulence, I think this is something that is emerging. So there's 2 things that when we look at Delta, when we compare it to Delta, is it less severe than Delta? I think there is a broad consensus now. It is probably less severe than Delta. But I think the distinction to make is by no way mild per se. All right. So why I say that is, yes, it's a less severe disease than Delta if the person is, had vaccination, if the person has got a booster dose, for example, of vaccines. But for a person who's got none of all that, it might not be the case. And particularly if somebody has got underlying comorbidities and has got not appropriate protection either from vaccination and boosting, it might not be the case. So yes, relative to Delta, it's a less severe disease, but by no ways is a mild disease per se by itself. There is also some postulation that is probably more intrinsically less severe, and there's early lab data to say perhaps now there is preference for replicating in the upper respiratory tract as compared to lung, and perhaps that's why you're seeing a less severity in disease intrinsically to explain that. But what's important to remember is when you have a disease which is half as severe, but you have 10 times the more the people infected, you're still gonna get a huge number of people ending up in hospital simply because of the sheer number of people getting infected. So that's important distinction to make when it comes to Omicron in that context. Just a bit of a graph on an Omicron wave in South Africa. Gauteng was the first province which experienced the wave, and the scientists from Botswana and South Africa eventually informed the world of Omicron. And these were the case trends and trajectories when we are looking at admissions in hospital. Important to remember, South Africa, the population is a younger population, number one. They had multiple waves with Alpha, Beta, and Delta COVID cases prior to that. So you had a huge population of patients who had prior exposure to infection. The case deaths, I mean, any death is unfortunate, but in comparison, they've had lesser death in the Omicron wave as compared to the Delta wave, and when they counted for cases. But I think this is a graph that recently produced. I just want to draw your attention is, although there were cases in hospitals and accounted for deaths being much lesser, there was still excess death at the Omicron wave, perhaps that was not captured. So early data indicate perhaps it causes less amount of death and ICU admissions, but important to remember in this context, they still had excess death in South Africa. The current epicenter in the UK and the main within the UK context at the moment is London. London is about 2 weeks ahead from the trajectory of cases in other parts of the UK, and this is the London experience. They had a huge surge of cases. At one point, 1 in 10 people in London was actually, had COVID at a particular point. So literally, the huge number of people who had infection with COVID in the Omicron wave, indicating to a lot of people also had infections, and the sheer number of people who got infected at a particular point. And you can see the numbers were humongously high here. What was reassuring in the UK experience is the number of deaths and number of ventilated patients did not go up as high as the previous wave in Delta. And I'll try to sort of untangle that in perhaps the next few slides. They still had number of patients going into hospital being a significantly high proportion of people coming into hospital, but the death and ventilated rates were did not go in the same trajectory as in number of patients. And this is a slide that want to draw attention and look at the context. Here, the over 65s and the number of people who got boosted in the UK is a huge proportion. Context is important, you see. In the UK, they have the booster exercise was a national exercise where everybody went and got boosted. You had particularly the older age groups who got significantly boosted. And if you look at the trajectory of cases, particularly when it comes to ICU admissions, in England and the United States, it's a little different. So in England, the COVID ICU cases seems to have not followed the trajectory of case counts, whereas in the United States, it's going up as well. I think the other thing to look at is the number of people who've been exposed to COVID in the UK and the US, even for that matter, is perhaps very different from Malaysia. So I think that's something to keep in mind when we speak about relativeness or whether how bad a country might be hit with the Omicron wave. We've got very good vaccination rates. We have to get our boosting rates up to these levels for the general population, and then hopefully the Omicron wave will not be too bad and something that we can manage. And what we've learned from UK is hospitalization from COVID is high, all right? So there are a lot of people who are going into hospitals for COVID, simply because when you have a large number of people exposed, you're going to have a lot of people going into hospital. Simply because there are a lot of people who are vulnerable as well, all right? Number two, 1/3 of the cases in hospital is incidentally admitted for COVID, and 2/3 of the cases around that region is admitted for COVID-related pneumonia. And the other thing is a lot of healthcare workers and social care workers are isolating for COVID, all right? So when you have the situation of you have a lot of hospitalizations because of vulnerable people getting COVID, and you have the situation where a lot of healthcare workers are needing to isolate because of COVID. At one point during New Year, I think there was close to 50,000 healthcare workers who were isolating for COVID or being COVID-related illnesses. So you can imagine hospitals are short-staffed together with rising hospital rates because of the sheer number of infections. So that's the situation here. The ventilation rates obviously have not seen the levels that you've seen with Delta, but important to keep in mind they have reached boosting levels of perhaps one of the highest in Europe and perhaps one of the highest in the world as well. From context of UK, they've revised their isolation guidelines for patients who have COVID. So if somebody has COVID and is at home and is better, at day 6, they can do a lateral flow test. If it's negative, they repeat a lateral flow test at day 7. If these two tests are negative, they can go out of isolation. If these two tests are not negative, they have to wait until 2 consequent tests is negative and they can go out of isolation. So they've tried to reduce the isolation days, pragmatically speaking, because when you have that many people infected or exposed, you're going to get a lot of people isolating, and when there's a lot of people isolating, a lot of services, not only healthcare, but services like taking the train or taking the bus, or somebody's going to take a flight. So a lot of essential services will be affected as well. Just a few other slides from the Malaysian experience of vaccination. I think again trying to highlight this is difference in rate for people who are incidence mortality rate per 100,000 population in people who didn't have vaccine in the red line here, as compared to somebody who has fully vaccinated and boosted. And you can see the market difference even at the oldest age. When somebody has vaccinated and boosted and compared to not vaccinated, there's a market difference in mortality rate. And again, when you look at by type of vaccine, when you're not vaccinated, the rates of mortality is much higher. And this is incidence of COVID for somebody who's received boosters and not received boosters, and somebody who's not vaccinated. And this is just a slide to illustrate what the situation is like. Omicron, because of the capacity to cause reinfection, you're still going to get a huge proportion of people getting infected and severe disease in the most vulnerable group, and particularly for people who are not vaccinated. So I think that the key feature moving forward was going to be what kind of population rates of vaccination we're going to get. And for the elderly group, the over 60s, the boosting percentage is going to be incredibly important, especially, and also for people who have underlying comorbidities. And these are data from the UK Health Security Agency looking at the effectiveness of boosting and protection against hospitalization. I think we've got to be quite conscious that symptomatic disease for somebody who has catch COVID after vaccination might and will happen, but what's important is how well it protects you from getting to hospital, how well it protects you from ICU admission, how well it protects you from death. And there's good indication that after boosting, the rates of hospitalization is protection rates are about 88%. And recently, I think they just published again for people over 65 years old who receive boosters, the protection against hospitalization is about close to 90%. And why do we need boosters? This is data from the Malaysian NIH, which looked at waning immunity for COVID infection, ICU admissions, and death. You can see the protection against death is still quite robust, about 90% for the Pfizer vaccine and 78% for the Sinovac vaccine. But there's obviously a definite waning in protection from symptomatic infection. So I think the current Malaysian guidelines is to get people vaccinated 3 months from their initial 2 doses, and I think that's the way to go forward. Important for people to get their booster dose vaccine. Then the question you always get is whether you're going to get vaccinated every 6 months. Pragmatically speaking, I think for patients who have vulnerabilities, who have medical conditions, this might be something that we'll have to look at, perhaps for something that comes perhaps to influenza-like vaccination, a yearly vaccination but people who are otherwise well, perhaps might not be requiring vaccination as often. So these are something that's evolving, something that the science will be guiding, and as we know what we are seeing, we perhaps can make more informed decisions. And just the last slide on improving protection against COVID-19. You have the personal responsibilities of the individual and the shared responsibilities where you can do at workplaces, government support messaging and vaccination. There's no one panacea or tool to prevent COVID-19 or surges in any particular country, but it has to be a whole host of tools, and only then you can break the chain of infections, and only then perhaps we can control the surges and lift with COVID-19. With that, I'll thank you, and I'll perhaps be happy to discuss if there are any questions. So thank you very much.
Thank you, Dr. Giri, for that very informative and interesting presentation. Dr. Giri, now...
You're welcome.
Dr. Giri will now address the question in the YouTube chat platform. There's one question at the moment. I'll read it out from Dr. Saijan. At the current situation, when you think our country will be considered as endemic?
So, I mean, the thing is, what we are sure is COVID is going to stay with us, right? So COVID is going to be here, and you might have new variants coming up. The situation is when a new variant comes up, what happens to the individual, number one, number two, the population, and number three, the capacity of the healthcare system. So if we look at the UK experience, what they have done is they have tried to sort of live with the Omicron wave, instruct or advise people to take the precautions which they should, which is wearing masks and doing lateral flow tests. So lateral flow test in the UK is free. Everybody gets it for free, in the sense that you can get it by post, you can get it at home, and what the advice is, before you go out to a large gathering, before you go and see a vulnerable friend, before you go and see your grandmother who might be at risk, you do a lateral flow test and go. So I think that would be the way going forward, at least until we get case counts and case situations stabilized in the country. So would be obviously getting vaccinated, getting boosted, wearing your mask, which Malaysia, I think most people do really well, and the rapid test, using it as a tool to protect yourself, number one, and so protect others, particularly at higher risk. So once a particular country has the capacity to manage the case counts and the health system is not threatened anymore, and then COVID will naturally be another disease which is, most of us see on a daily basis in our practice settings. So when is that going to be? Perhaps in the next 2 years, perhaps next 1 year. But until now, what we're seeing is a large proportion of people getting infected with new variants, and that's obviously changing the dynamics every time we speak about trying to live with COVID naturally. But at the moment, we are living with COVID. At the moment, we are trying to manage our daily lives with COVID. So that's going to be the situation at least for next 1 year moving forward.
Thank you. Next question is from Dr. Saijan Samit again. Why booster we need to have to use mRNA instead of from the China one?
Okay, all right. So when they looked at, I'll speak particularly at Omicron. All right, when they looked at Omicron, they looked at neutralizing antibodies. So neutralizing antibodies is just one part of the immune system. It's not the other part, the T cell response. They look at antibody response only. When they compared Sinovac and Pfizer, Sinovac didn't seem to produce neutralizing antibody response. We don't know about the T cell response, but they didn't seem to produce enough neutralizing antibody response to Omicron in particular. Pfizer definitely also had decrease, but they still had neutralizing antibody response to Omicron. So that's one of the reasons why Pfizer, the current recommended vaccine for the boosters for COVID-19. So as obviously as anything in science, if you have data to say that one seems to be a little better in that current condition at the moment, that would be the advice moving forward, and hence that's why people who got the Sinovac vaccine recommended for the moment to get the Pfizer vaccine as the booster.
Thank you, Dr. Giri. Question from me. Probably you could explain a little bit about the lateral flow test in comparison with the saliva test kit that we're having here in Malaysia.
All right. So the lateral flow test is basically also a rapid test kit. So what they do is basically do a swab in the nose, and then you put a buffer solution and you wait for about 30 minutes and look at what the results are. So it's a lot of times similar. And again, I think the caveat, even if you use a saliva test, is how the procedure is done. All right. So even if you do a lateral flow test and you don't do it properly, you're not going to get accurate results. So what is important for most of these tests is it's done appropriately. That means if you are supposed to put it in a buffer solution for about 30 seconds, then yes, 30 seconds. You're supposed to wait for 30 minutes before reading the results, wait for 30 minutes before reading the results. So those are the smaller aspects when you're doing the self-test kits, but I think it's just as important because even if you use one inappropriately and you get a result, it's not going to be really helpful. So look at the smaller details of these tests, and for example, how long you put in a buffer test, how long before you wait and read the result, and those things are might be different from test to test, and the test that you use, make sure that it's appropriately done as the manufacturer guidance. When it's most useful, number one, for people who are most infectious. All right, if you don't have symptoms, or you just had symptoms for day 1, day 2, the lateral flow test and the rapid antigen test are most useful at that point for the most infectious patients. Once you have passed the infectious phase, usually day 5, day 6, day 7 onwards, the pickup rate usually goes down, and that's because the function of the test is usually to pick up people who are most infectious, and you have symptoms after this date, or you have symptoms and you have persistent negative lateral flow test, a PCR test would be beneficial, because that's where you're going to pick up the higher people, the percentage of people who passed the infectious phase, but didn't be picked up on the rapid antigen test or lateral flow test.
Thank you. Again, another question from me. What is the latest news about this ivermectin treatment for COVID? Could you just comment a little bit on that?
All right, soalan cepu mas.
Yeah,
okay.
betul.
So, right. So, I think we all agree that we would like repurposed medication, which is cheap, which is available, and can be taken by people, right? And dexamethasone is one of that. Dexamethasone is a repurposed medication, cheap, available, and can be taken, widely available. The thing about ivermectin is, at the moment, from all the meta-analysis or the recent meta-analysis, which took the most robust studies, I'm not talking about just generally all these studies, but just the most robust studies, is not shown to be beneficial. That being said, there is a huge trial which would change all those meta-analysis results, which is being conducted in the UK as well, and they're hopefully finishing recruiting soon, which is called the Principal trial. Here is outpatient setting again, ivermectin versus no ivermectin, and they're looking at hospitalization rates for patients who took ivermectin and did not take ivermectin. So at the moment, based on the evidence that's available at the moment, I can't recommend ivermectin as a tool to be given to people, to patients. But that being said, we are waiting for evidence from the Principal trial, whether it will change. We don't know. We wait for a trial. The meta-analysis I mentioned, from the most robust ones, have not shown benefit. So yeah, that's where we are. We definitely hope it worked, or hope it works, but at the moment the evidence is not there that it works.
Thank you. All right, next question from Dr. Wan. Is it normal to get COVID-19 more than once in a year?
So I think we spoke about it little just now. With Omicron, you can get reinfection of COVID-19, but generally saying now, we think that if you got COVID-19, you should be protected at least for the next 90 days. But moving forward, yes, you can get infection. How often? Perhaps after 90 days. And definitely with Omicron, you can get reinfection. So, yeah, I hope that answers the question. You can get reinfection of COVID-19, but we think it shouldn't be within the first 90 days.
All right, thank you. Next question from Dr. Saijan. Does new antiviral effective against Omicron?
All right, so there are a couple of antivirals which are available currently. I mean, traditionally we know about remdesivir, and most, I think, countries use that initially. India had a generic version of it which they used. Malaysia, until end of last year, we're just trying to get remdesivir in for use for our patients. And there's two other ones, one by Pfizer, which have shown encouraging results, and there's also another one from, if I recall, I think it's AstraZeneca, which has shown encouraging results. Again, any antiviral, if it's used, it has to be used very early on, and usually by the time patient comes to hospital, it might not be early. When I say early, is patients coming to hospital usually present at the second week of illness. So yes, context, antivirals, newer ones available, it's showing encouraging results, and it should work. Number two, availability at the moment in Malaysia is not available as widely, but remdesivir is coming through to be available. And number three, if you're going to use, it has to be used really early, and perhaps it would be beneficial for the most high-risk patients. That means if you had malignancies, if you have end-stage renal failure, if you have if you're immunosuppressive therapy. So those are the groups perhaps who will benefit the most initially, because you're going to have limited numbers available, and also the next context is they have to be given early.
Thank you. The next question is from Dr. Wan. Is there any specific reason why people get COVID-19 even after booster dose?
Okay, so I think what we have to sort of look at in particular, we have to differentiate between getting infection and getting disease. When I say disease here, I'm meaning severe disease requiring somebody to go to hospital, requiring somebody to go to ICU. So infection is usually mediated by your humoral response, that means the B cell antibody response. Okay, and we know with Omicron, the antibody response can be overcome significantly, and with boosters, although it's helpful, it still wanes over time, right? So somebody who's exposed can get infected. That means you might have mild symptoms, you might have a running nose, you might have a slight fever, you might have a slight sore throat, might have a slight cough. But what is important is, and I think for vaccines, the whole purpose of vaccine, it protects you from getting to hospitals and dying from the disease. So what is robust, what the evidence that's coming through is the booster dose does that. And I think it's one of the best places to look at is actually a comparison between two countries which are having surges currently. So UK and the US are both having Omicron surges. And if you look at the comparison of booster dose which is administered in the UK, is particularly for the elderly group more than 60s, is much higher proportion than in the US. And if you see the ventilation rates and ICU admissions in the UK compared to the US, is different. So those are very robust indications that the booster dose is doing its job for the most important endpoints, which is protection from hospitalization, death. But getting symptomatic disease, yes, you may be able to, because as I mentioned, we discussed this now, the waning antibody response itself.
Thank you very much, Dr. Giri. I think we finished addressing the question at the moment, unless there are last minute questions later on. But at this moment, I just want to thank you all the participating members watching this YouTube live seminar. In a short while, we'll be displaying the QR code, and please scan the QR code using your MMA apps to register your point. If you have trouble scanning the QR code, please register as soon as possible in the link provided in the WhatsApp group earlier on. I just also want to thank you, our Secretariat, Ms. Melissa and Mr. Adrian, for their assistance throughout this live web seminar. Thank you to our sponsor, Kuala Lumpur International Healthcare Center, Pet Lab and Diagnostic Care. Before we end the session, I will just give this opportunity to Dr. Giri again to say few parting words to all of us here in Sabah.
All right. Again, Sabah is very close to my heart, and being there obviously will always be my first priority. Thank you very much for the invitation, and I hope all of you all are staying healthy and well. And I think the lessons we can learn, at least from the UK experience from Omicron, is it's going to come. I think it's not a matter of when, but a matter of if, not matter if, but a matter of when now. And from the experience, what we've learned is a lot of people are probably going to get infected. The sheer number of people are going to get exposed and infected is probably going to be quite a number of them. So the protection of what we are doing now is obviously we have to continue what we are doing from our wearing masks, and obviously very importantly to get the population as boosted as high as possible. And the next thing is, I think there should be a more widespread use of lateral flow or our saliva tests when we are going to see vulnerable patients, or even going to meet in a group. For example, you're going to meet a group of friends, and you want to protect each other. The best way to do it is perhaps everybody doing a lateral flow test. again, the economics of it, I don't know how feasible is it, because um, purchasing one is not easy, particularly for people who have the income rates is not great. So, but it's something that we should look at how we can make it more widely available so we can protect each other. So hopefully I'll see you all soon, and thank you very much for the invitation once again to the committee.
Thank you very much again, Dr. Giri. I think the message that we are getting here is Omicron will come to Malaysia, so be ready, get yourself boosted, and use your saliva test frequently, especially when you seeing people in large group. Okay guys, we will see you again in 2 weeks time. In the meantime, take care and thank you.
Thank you.
That was wonderful, Dr. Giri.